Good morning, everyone. So today, Dr. Prashant and I would be presenting a review article titled as Optimizing Dysphagia Management in Head and Neck Cancer Radiotherapy, Advanced Imaging, Precision Dosimetry, and Rehabilitation. The authors are from the Department of Radiation Oncology and Medical Oncology from Chittaranjan National Cancer Institute, Kolkata. So, as we all know, head and neck cancer is the seventh most common cancer with big numbers of new cases and deaths annually. This has a significant disease burden that highlights the necessity for effective treatment strategies that balances between both the oncologic control and the functional preservation. Radical radiotherapy combined with concurrent chemotherapy remains the standard approach for advanced stage disease, providing a viable organ preservation alternative to the surgery. Now, it's not about just the mere survival. It is essential to evaluate the treatment outcomes in terms of the post therapy quality of life. The functional integrity, that is, after the treatment, how well the organ is functioning, that determines the overall success of the organ preservation strategies. So, as we all know, xerostomia, that is dry mouth, and dysphagia, they rank as the major post treatment complications and are the crucial determinants of the diminished quality of life. So, traditionally, xerostomia was considered to be a primary contributor, but the recent evidence suggests that dysphagia more is the affects the quality of life more than xerostomia, especially in the first 18 months after the radiotherapy. Moving on to the advancements in the radiation therapy, the introduction of intensity modulated radiotherapy with image guidance has significantly enhanced the organ preservation by sparing the critical structures, which are the dysphagia and the aspiration related structures. And it has emerged as a strategic approach to mitigate the post treatment swallowing impairments and improve the quality of life. Now, along with the benefits, there are challenges also associated with the IMRT. The anatomical proximity of the DAS structures to the tumor sites, especially in the laryngeal and the pharyngeal cancers, it complicates the precise reduction of dose without compromising the oncologic efficacy. So, achieving a balance between the tumor eradication and the functional preservation requires sophisticated contouring techniques and advanced dosimetric strategies. So the reviews of this narrative article is objectives are to integrate the insights from the pathophysiology, radiological assessment, contouring methodologies, and dose optimization strategies for DARS. The review highlights the importance of the standardized assessment tools and evidence-based rehabilitation interventions to enhance the post-treatment swallowing function. Its goal is to address the morbidity that is associated with radiation, refine the clinical strategies, and thereby improving the quality of life. So, before knowing how the radiation affects dysphagia, it is important to know what is normal swallow. So, it's a precise neuromuscular function that has coordination from the nerves as well as the mastication muscles, the laryngeal and the pharyngeal muscles. So, the first phase, oral phase, is divided into two, the preparatory phase and the transition phase. So it's a voluntary phase. It requires the lip seal and the food is chewed and the saliva is mixed to form a bolus. Now, once this bolus is formed, it is transitioned with the anterior and posterior movement of the tongue into the oropharynx. And the oropharynx has the receptors that triggers the pharyngeal swallow. Now starts the pharyngeal swallow, which is voluntary as well as involuntary. So it requires the palatal seal so that the food does not go into the nasal cavity. And then simultaneously, the elevation of the hyoid bone. So that hyoid bone elevation enables the epiglottis to retroflex and simultaneous opening of the UES. So all this mechanism has to be in a timely manner, coordinated manner. A slight delay in the elevation or a slight delay in opening of the UES, it all will result into either aspiration or accumulation of the residue. And finally, the esophageal phase. once the food enters the UES, upper esophageal sphincter. So once it enters the UES, then it's the completely involuntary phase. With the help of the peristaltic movement of the esophagus, the food is then passed on to the lower esophagus sphincter and then finally into the stomach. So once we have understood how the process is complex, it has the susceptibility to the disruption. It can be disrupted at any stage, right from the lip till the stomach. So the radiation induced changes can significantly impair this coordination, resulting in dysfunction, which further compromises the nutrition, the quality of life, the treatment adherence, which requires a systematic framework for early detection of dysphagia and tailored management approaches to manage the same. Although the tumor progression can directly impair the swallowing, dysphagia more often stems from the residual damage to the dysphagia and aspiration related structures and the neuromuscular dysfunction. Xerostomia, without the saliva, there is a problem in the formation of the bolus. So the solid food are very difficult to swallow. And finally, factors like general condition of the patient, the pain, impaired pulmonary function, severe nausea, GERD, they also significantly impair the swallowing function. The radiation-induced dysphagia, it arises primarily from the direct tissue damage or the progressive fibrosis affecting the DARS. So talking about the functional changes after radiotherapy, there have been several video fluoroscopic studies which study the swallow after the radiation. And these studies have shown that there is a reduction post radiation, there is a reduction in the pharyngeal peristalsis. There is an impaired synchronization of the pharyngeal contractions, which will not allow the bolus to flow effectively. So there will be a lot of residue in the oropharynx. Additionally, the diminished posterior inversion of the tongue base, it also reduces the bolus propulsion. Compromised laryngeal closure, as I told you, the delay in the hyolaryngeal elevation will all compromise the laryngeal closure, leading to aspiration. There is a reduction in the hyoid bone elevation, a delayed opening of UES. All these things are seen post radiation in the video fluoroscopy. Now, beyond this pathophysiological changes, as I explained earlier, there are symptoms that directly affect the daily functioning of the patient. So the common issues include difficulties with eating, necessary dietary modifications, social withdrawing during the meals, and anxiety about choking. These symptoms frequently extend beyond the acute treatment phase and are directly linked to the long-term treatment-related toxicities. So before I move on to the assessment, Dr. Prashant would be covering the radiation part.
You can the assessment.
I'll do it.
Yeah.
So the assessment now involves the subjective and the objective. So the subjective assessment would be the patient reported outcomes. That includes these listed ones have shown proper clinical efficacy in the evidences. So the MD Anderson dysphagia inventory, the European Organization for Research and Treatment Quality of Life assessment, and the functional assessment of the cancer therapy. So we get to know, looking at these scores, we get to know how the patient is directly affected by it, but we do not get to know about the mechanism of the swallow, how is it affected. So for that, objective evaluation is necessary. So in head and neck cancer, the video fluoroscopy is the gold standard objective assessment, but the setting up of VFSS is not really very easy and very expensive. So FEES, the fiber optic endoscopic evaluation, is also used. And finally, the PAS score, the utility of the PAS is there in the tracking longitudinal changes. So the subjective measures, they reveal the patient-reported quality of life, while the objective, they quantify the swallowing biomechanics and they identify the silent aspiration, which we could not see in the clinical. The clinical examination often misses the silent aspiration. So all that we can quantify in the objective evaluation. Studies highlight post-treatment deterioration and increased aspiration risk, emphasizing the need for both the approaches to improve the diagnostic accuracy and tailor interventions, enhancing the patient outcomes.
Good morning, everyone. So we'll be looking at how radiotherapy affects swallowing. Stops the first. Let's share screen. We will have to share yours. We'll have to share your screen. This basically. Is it visible? Like,
It's a short piercing through.
That's fine, no? Yeah, okay. So we'll be discussing radiation-induced dysphagia, where you can see dysphagia can be either be short-term or long-term. And when you see the number of patients that complain, it's almost about half of the patients will have some kind of painful swallow or temporary tube dependence, difficulty in swallowing in the acute phase. And then long-term, some of the patients will have permanent feeding tube requirement or persistent difficulty in swallowing. So we are already aware of the mechanism of action of radiotherapy. And here you basically have either the direct effect on the DNA or the indirect effect, which causes hydrolysis of the water molecules into reactive oxygen species, which then uh, leads to pro-inflammatory cytokine chemokine release. And this oxidative damage is what leads to inflammation and the release of certain immune responses within the tissue. And this is beneficial for tumor cell kill, but it also leads to side effects. The acute effects typically you would designate in the first 90 days. Anything beyond 90 days is a late effect, and late effects predominantly. High floating meeting control there only more in that high floating meeting. Okay. So this inflammatory response is what leads to edema and capillary leak, which in turn leads to epithelial cell death. And in skin and mucosa, there is loss of barrier function. There's also late vascular endothelial damage and late fibrosis, which combined lead to loss of function in the organs. What we are discussing today specifically are the muscles related to swallowing, which are the pharyngeal constrictor muscles, and this is broadly your superior constrictor, middle, and inferior constrictors. So when you look at the RTOG grading, which is specific for radiotherapy, this has not been updated since the late 90s, but it's a simple score to understand mild, moderate, and severe dysphagia. The added caveat is that severe dysphagia is also designated when you have a weight loss of greater than 15% or you have NGT dependence. CTCAE is more patient specific in the sense that it deals with the patient's symptom. So if the patient is able to have a regular diet, but with some difficulty, it's grade one. Grade two would be if you're limited to a semi-solid diet. Grade three would be if you're on a complete liquid diet, or if you're NGT dependent. So the histopathology behind these changes are either you would have a late radiation-induced mucositis, which is seen as discoloration, thinning, rigidity, or induration of the subcutaneous tissue of the mucosa. And this may progress in rare cases to ulceration and necrosis. Then you have muscular involvement. So the pharyngeal constrictors that we spoke about, these are the primary muscles uh, that are involved in swallowing. And here you can see an increase in thickness from a pre-radiotherapy to a post-radiotherapy to the tune of maybe from 2 mm to 7 mm. And this is as a result of edema and subsequent induration. There's also an impact on the muscles of mastication, which can lead to trismus, and cartilage thinning and synovial fluid depletion, which leads to temporomandibular joint dysfunction. There's also neural impairment of the pharyngeal plexus, which are basically consisting of the cranial nerves 5, 7, 9, and 10. And mucosal damage to the innervation of this pharyngeal plexus is what leads to disruption of both afferent and efferent neural pathways, and this leads to sensory and motor deficits. Other histological basis for damage would either be persistent inflammation, fibrosis, microvascular injury, muscle atrophy, and neural disruption. And these translate into radiological findings as well. So this study has gone and looked at patients' MRIs that were done pre-radiotherapy and 3 months after radiotherapy. And what they saw is that there is reduction in the T1 weightage intensity and an increase in the T2 weightage intensity, which points towards increase in edema. And here, this is evident in the T2 imaging over here, where you can see the pharyngeal constrictors are darker in the pre-radiotherapy, but they're almost completely white post-radiotherapy. And this is more prominent when you receive a dose greater than 50 gray, where the average mean, where the difference is more pronounced as compared to when the constrictors receive less than 50 gray. They also looked at the muscle thickness and they saw that there was a increase in the muscle thickness post treatment, and this was again more pronounced when the dose was greater than 50 gray. Coming to the DAR structures, so these are basically the most important structures for swallowing that we ourselves draw for sparing during radiotherapy when we're doing IMRT especially. And even though there are a lot many muscles that are involved in swallowing to the tune of about 30. What we focus on are the pharyngeal constrictors, the esophageal inlet, and the cervical esophagus. Anteriorly, the base tongue, supraglottis, and the glottis. The base tongue we don't draw separately, it comes as part of your oral cavity, but we draw the supraglottis and glottis separately. So this is what it looks like when you draw on the actual sequences. So you have your superior constrictor, middle constrictor, inferior, your thoracic inlet, that is your cricopharynx, and the cervical esophagus. So there are certain demarcations that we use for the drawing of these structures. So the superior pharyngeal constrictors, you start drawing from the where you see the hamulus. From there, you would draw till the upper border of the hyoid. Between the upper and lower border is your middle pharyngeal constrictor, and from your lower border of hyoid to the lower border of cricoid area, inferior pharyngeal constrictor. The cricopharynx is drawn from that point till the first tracheal ring, and 1 centimeter below the first tracheal ring is your esophageal inlet. Below that, you have your cervical esophagus till the thoracic inlet. So coming to IMRT, these are the dose constraints that we give to the system to so basically these are certain functions that we have to give to the system to limit the doses to the structure. So broadly, these are 50 gray, but because middle pharyngeal constrictors are a little more important, and they are smaller also in size. So you may benefit if you reduce them to 45 gray. And this is a patient that we have treated. So this is our own case where we have given a very high dose up to 70 gray to the green area, and then bilateral level 2. This is actually your high level 2. The pre the pre-styloid, retrostyloid group of lymph nodes that is receiving a high intermediate dose. And you can see that despite these two receiving 60 to 70 gray, the orange area, which is your 30 gray volume, is still being spared from your lips, buccal mucosa, and the parotids. So similarly, when you come down, you will find the muscle constrictors and the supraglottis over here being drawn. And over here, we have limited the dose to midline to 50 gray. So what you see in dark blue over here is the 50 gray dose, and it just touches the structures laterally, but doesn't come up to midline. So if you reduce the dose to these structures, you would assume that your level of dysphagia would be lower, and reducing the dose to the larynx reduces your chance of aspiration. So this is a very early study that was done in the University of Michigan and published in 2004, where they compared 3D CRT, because that time IMRT was just coming into the fore, and they have done standard IMRT without giving any dose constraints to the DAS structures, and they have done DO IMRT. So wherever you say DO IMRT, that is this dose optimized IMRT for the DAS structures. So here they have limited the DAS structures to 50 gray. And they looked at the doses to the constrictors first. So you can see from the diagram here that the highest dose to the pharyngeal constrictors are being received in the 3D CRT, followed by the standard IMRT, followed by the dose optimized IMRT. And they were able to reduce these in increments of 10%. So you had 10% lesser average dose to the constrictors in the standard IMRT, and then another 10% in the dose optimized IMRT. Similarly, for the larynx, there was a 7% reduction in dose to the larynx in standard IMRT, and then with dose optimized, it was another 11%. This is just a dosimetric study which showed that this kind of dose optimized IMRT is feasible, but they didn't actually look at the functions. This study that is from our own TMH was published in 2024, where you can see that they have drawn the DAS structures, and then they have also drawn the PTV, which is actually going to receive the dose. So because your PTV a lot of the times involves the DAS structures, you have to subtract that from the DAS. So you get a structure which is DAS minus PTV, which actually receives your dose constraints, because you cannot compromise the doses to the target volume. So a lot of the times those structures have to be given a full dose, and only the surrounding structures can be spared. So here they've adequately spared the 50 gray spill beyond the PTV. And what they saw that the mean dose to the DAS as per the primary site in the entire group was 47%, so less than 50 gray. But in the oropharyngeal cases, it was greater than 50 gray. In the laryngopharynx, it was 44. So basically, they were not able to adequately reduce the DAS dose in the oropharyngeal group, and this was statistically significant. The mean dose to the DAS structures, as per the nodal involvement in N0 and unilateral, they were able to reduce to less than 50 gray, but in bilateral, again, the mean dose received was 55 gray. So what they determined was that if your PTV as a whole is going to be less than 150 cc, then you will be more better placed to spare the DAS structures. You have to understand that we are contouring the DAS structures, you're contouring the PTV. This is just telling you what the DAS minus PTV is getting. But if your PTV is going to be large, then whatever's the DAS structures inside that, you're not actually calculating the dose, but it will be significant. So this is your level 1 evidence for DAS optimization. And this is by Nutting et al., published in Lancet in 2023, where you had 22 centers from UK taking patients of oropharyngeal and hypopharyngeal CA, and they have randomized to dose optimized versus standard IMRT, where 65 gray was given to the primary and involved nodes and 54 gray as a standard to the elective sites. The volume of the superior and middle constrictor was taken together and inferior constrictor was taken separately, and both were given a constraint of 50 gray. And the primary endpoint was the MDADI composite score at 12 months. So it was a positive trial. There was a significant higher MDADI score in the dose optimized IMRT, which was 77.7 versus 70.6 with a mean difference of 7.2. And you can see uh, that in the diagram as well, the baseline scores are almost the same, after which there is a immediate dip in the scores at 3 months, and progressively there is improvement, which is a little sharper in the dose optimized, which is the first group here, versus the standard, where it is a little stagnant. So when they looked at the change from baseline, they saw something similar where the baseline scores being the same, there was a drop in both at 3 months, but a little lesser in the dose optimized. But what was important was that the subsequent recovery at 6, 12, 18, up to 24 months was a lot better in the IMRT, which was dose optimized versus the standard IMRT. And the proportion of patients that showed improvement at 24 months was significant in the dose optimized, with fewer patients worsening. But this was not seen in the standard IMRT arm. So we already have level 1 evidence for doing dose optimized DAS pairing in IMRT. The idea of doing the same in protons, and because protons is supposed to give you a better dose distribution. So what you see with protons is that the dose fall off is very sharp just beyond your target, is the main dosimetric benefit that you get. But everything else about protons, from the mechanism of action to your target, is going to be the same. So this was the torpedo study that was published in abstract form. So the abstract was a late breaking presentation in Astro 2025, just a few months back, I think a month back. And 205 patients were enrolled with a 2:1 ratio of randomization to IMPT versus IMRT. Both groups were treated to 70 gray and 33 fractions with 2 cycles of high dose cisplatin at 100 mg per meter square, with co-primary endpoints at 12 months of clinician reported gastrostomy dependence and CTC grading, along with patient reported outcomes, which was taken as the University of Washington Quality of Life Composite Score, which addresses saliva, taste, chewing, swallowing, speech, and appearance. Secondary endpoints were your MDADI score and locoregional recurrence and overall survival. So the main paper is yet to be published, but what they showed us was the toxicity analysis, where feeding tube dependence was extremely low, 1.7% in both arms, so identical. Severe weight loss was actually more frequent with protons, 18.2% versus 5.7%. Patient reported quality of life was identical, swallowing outcomes were identical, and disease outcomes were identical. Excellent, actually. At 2 years, you had 95% locoregional control and overall survival in both arms. The takeaway here from the investigators is that there's no requirement of IMPT in oropharyngeal cancer, which is something that we have been trying to explain to patients, because when your target itself is the pharynx, then there is not much that you can spare beyond that. When it comes to xerostomia, you may still have some benefit, but we are relatively able to do a good job with IMRT as well. Even if you have a short-term benefit when it comes to acute toxicity, in the long term, I think even in TMS, they are seeing a greater risk of necrosis because of the kind of doses that you achieve within the tumor. So there is a learning curve here, but in UK, these were all experience centers. They have been doing protons for a long time. And now you have randomized evidence that there is no benefit in terms of toxicity, at least. So that is from my side.
What an excellent presentation, Prashant and Yasha, both of you.
Sir,
How-
my lab part is left for 5 minutes.
Yes, go ahead, please. Go ahead.
Moving on to the last part, that is the rehabilitation. So the assessment itself is not enough. The assessment will help us to guide that what each patient's requirement is. And the dysphagia rehabilitation is a vital one, but yet overlooked aspect because the resources and the specialized expertise are very scarce in the developing countries. Next important factor is the timing of the rehabilitation exercises. So the main cause of radiation-induced dysphagia is the fibrosis. And once the fibrosis has already begun, the exercises won't help that much. So it's very important to start the swallowing exercises, the prophylactic swallowing exercises before the radiation is initiated. And secondly, the adherence on a daily basis is very, very critical. So usually after 10 or 15 radiation cycles, they have pain and mucositis and they stop doing the swallowing exercises. So that really won't help much. So research indicates that patients who commence the swallowing exercises pre and during radiotherapy report a significantly enhanced quality of life compared to those who start post-treatment when the damage is already done. So moving on to the postural adjustments, the evidence shows that 80% these adjustments can prevent aspiration in 80%, 81% of the head and neck cancers. And these are the list of the maneuvers. Now, these maneuvers are not for all the patients. It depends on what the problem is. So I would just explain the chin down maneuver. It helps in narrowing the airway. The tongue base is protruded behind posteriorly. So the airway is narrow. So this is useful in laryngeal and pharyngeal cancers and not in glossectomy, because if we do this in glossectomy, there is no propulsion of the bolus already. Second is the head back. Now this is what we can use in glossectomy cases, where with the use of the gravity, the bolus is directed backwards into the esophagus. Third is the head rotation maneuver. This is helpful in the cases of unilateral cord paralysis, where suppose my left cord is not working. So I would ask the patient to move the head towards the left. So to compromise the muscle that are already impaired and direct the bolus towards the stronger side. And third is the head tilt. Now this is done towards the stronger side. Suppose there is no lip seal here. So I would ask the patient to tilt their head to the opposite side to direct the bolus backwards. These were the postural adjustments. Next, the swallowing maneuvers. So supraglottic swallow, as I have explained in my previous classes, it's about holding the breath tightly, swallowing the bolus, and then coughing down. The three steps are there in this. It's majorly used in laryngeal and pharyngeal cancers. Second is the Mendelssohn maneuver. So in this, we ask the patient to swallow the saliva only halfly. I mean, just feel the hyoid bone, swallow the saliva a bit. Once you feel there is a raise in the laryngeal complex, hold the larynx there. So this would prolong the UES opening time. The bolus will pass easily and then the hyolaryngeal complex comes down. So it helps in expanding the UES opening time. And next is the Masako maneuver. It is for the residue clearance. So we ask the patient to hold the tip of the tongue between the teeth and then swallow the saliva. So the tongue base muscles are strengthened here and the bolus passes effectively. The other exercises are the oral tongue range of motion, the laryngeal range of motion exercise, which involves the pitch variation from low pitch to high pitch. And the last one is the shaker's maneuver, where the suprahyoid muscles are strengthened. So we ask the patient to lie down, uh, raise their head, and watch the toes so that these muscles are strengthened here, which again helps in the effective opening of the UES. The assisted rehab techniques, these are more effective in the neurodysphagia, very less evidence is there in head and neck cancer. So in the neuromuscular electrical stimulation, there are electrodes put on the hyolaryngeal complex, which give a short amount of voltage, and the hyolaryngeal elevation is enhanced. And the thermotactile stimulation involves stimulating the oropharyngeal muscles with the ice. The laryngeal mirror is dipped in the ice for 5 to 10 minutes, and then it is stroked, so this also triggers the pharyngeal swallow. So mostly it's done for the neurodysphagia patients. Now moving on to the limitation of this narrative review. All the studies which they studied in the review had heterogeneous methodologies which without systematic quantitative analysis, which may introduce selection bias and limit reproducibility. Second is the variability in the patient population, the tumor characteristics, which compromises the external validity and generalizability of the findings. Third is the evidence that support DOE IMRT were relying on the small scale, that is single institution studies, lacking robust data from large randomized control trials to confirm the clinical efficacy. The long-term outcome imaging assessment, including the MRI and CT, they were susceptible to the inter-observer variability, potentially affecting the measurement accuracy. And the evidence about the dysphagia management and rehab, they comprised of only the observational study with a scarcity of prospective RCT to substantiate the efficacy of all these rehabilitation. So to conclude, this review underscores advances in managing the radiation-induced dysphagia. MRI and CT guide dose optimization, while dose optimized IMRT reduces the exposure to these structures, enhancing the swallowing outcomes. Balancing the tumor control with swallowing preservation remains challenging. Early rehab strengthens the function, highlighting the multidisciplinary care's role. And the future research should explore the proton therapy and de-intensification protocols through RCTs to reduce the morbidity. That's all.